The monitor flatlines at 3:17 a.m. Not the gentle decline you see in movies where numbers drift slowly downward while doctors speak in hushed voices about letting go. This is sudden, violent. A heart that was beating 90 times per minute simply stops. The green line on the screen goes flat, and the alarm screams a single, continuous note that cuts through the quiet of the night shift. I'm alone in the room when it happens. The patient is a 52-year-old woman named Catherine Morrison, and 20 minutes ago she was talking to me about her daughter's wedding next month. Now she's unresponsive, her skin the color of old newspaper, and I'm the only person standing between her and death. My hands are already moving before my brain fully processes what's happening. I hit the code button on the wall, the alarm that will bring the crash team running, and position myself at the side of her bed. I lock my fingers together, place the heel of my hand on the center of her chest, and push. 1, 2, 3, 4. The cardiac monitor continues its flat, endless scream. Somewhere in the hallway, I hear running footsteps, voices calling out, the metallic crash of the code cart being wheeled toward this room, but they're not here yet. Right now, it's just me and Catherine and the terrible mathematics of CPR. Push hard enough to circulate blood to her brain, but not so hard you break every rib in her chest. Push fast enough to maintain perfusion, but maintain your own energy, because this might go on for a very long time. 15, 16, 17. I'm 6 months into my residency at Hospital St. Halsted, and I've never run a code by myself before. I've assisted, I've observed, I've practiced on mannequins that don't bleed or die or have daughters getting married next month. But I've never been the one making the decisions when someone's heart stops. 28, 29, 30. I pause compressions to give 2 breaths through the bag valve mask, watching her chest rise and fall artificially, mechanically, because her body has forgotten how to do this on its own. The monitor remains flat. And then the code team bursts through the door. And what happens in the next 47 minutes will teach me more about medicine, about death, and about the strange space between giving up and refusing to let go than anything I learned in 4 years of medical school. My name is Dr. Noah Reyes, and most nights I still can't believe they let me practice medicine on real people. I'm 27 years old, first-year internal medicine resident at St. Halsted Hospital in a mid-sized American city, where winter comes early and stays late. The hospital is old, built in 1924, with modern wings attached like afterthoughts to the original brick structure. The heating system clanks and hisses, the elevators are unreliable, and the call rooms smell faintly of decades of residents who've slept and stressed and occasionally cried within their walls. But it's a good teaching hospital. The attendings are excellent, the nursing staff experienced, and the patient population diverse enough that you see everything from routine diabetes management to rare tropical diseases brought back by missionaries and travelers. I grew up in Houston, Texas, the son of immigrants who worked themselves to exhaustion so I could have opportunities they'd never dreamed of. My mother cleaned houses until her hands were raw and her knees gave out. My father drove delivery trucks gone for days at a time, his back permanently curved from years of lifting and loading. When I got my acceptance to medical school, my mother cried and lit candles at church for a week straight. My father just gripped my shoulders and said in Spanish, "Now you can help people the way we never could." So every patient I see carries that weight. Every decision I make echoes with their sacrifices, their expectations, their unspoken hope that I'll be worthy of what they gave up. The thing about residency that nobody tells you in medical school is how much of it happens at night. You work 12, 16, sometimes 24-hour shifts. You make critical decisions when you're so tired that simple arithmetic becomes difficult. You smile at patients and pretend you're confident when internally you're terrified of making a mistake that could cost someone their life. My co-residents and I have a dark joke. Medical school teaches you medicine. Residency teaches you survival. The difference is vast and humbling. I remember my first night on call, 3 months ago, though it feels like years. I'd been so nervous I couldn't eat dinner, just drank coffee and paced the residence lounge while waiting for my pager to go off. When it finally did, around 10 p.m., my hands shook so badly I could barely dial the number back. It had been a simple page. A patient needed pain medication reordered, but I'd spent 15 minutes reviewing the chart, double-checking drug interactions, calculating dosages, terrified of making a mistake that would harm someone. My senior resident, Sarah Chen, had found me at the nurse's station at 2 a.m., staring at a computer screen with exhausted eyes. "First night is always the hardest," she'd said, handing me a granola bar. "You think every decision is life or death. Eventually you learn which ones actually are. How do you tell the difference? experience, and a lot of mistakes that you survive and learn from. She'd paused. The fact that you're this careful, this thorough, that's good. It means you respect the responsibility. Just don't let the fear paralyze you. Tonight, or technically this morning, since it's past midnight, I'm on overnight call for internal medicine. That means I'm responsible for all the patients admitted to our service, roughly 30 people spread across 3 floors of the hospital. I handle new admissions from the emergency department, respond to pages from nurses about patients whose conditions are changing, and manage whatever crises emerge in the quiet hours when most people are sleeping. My attending physician, Dr. Marcus Webb, is home sleeping, available by phone if I need guidance but trusting me to handle routine matters independently. It's both empowering and terrifying. This transition from student to doctor, from supervised to autonomous, from protected to responsible. Dr. Webb has been my attending for the past 2 months, and I've learned more from him than from any other teacher in my medical education. He has this way of asking questions that force you to think deeply, to consider not just the medical facts, but the human context surrounding each case. Last week, we'd been discussing a patient with diabetes who kept missing appointments and not taking his medications. Another resident had dismissed him as non-compliant, but Dr. Webb had stopped us. "Never use that word," he'd said firmly. "It suggests the patient is being difficult or obstinate. Instead, ask yourself, what barriers exist that prevent this person from following the treatment plan? Can't afford medications? Can't read the instructions? Doesn't understand why they're important? Has cultural beliefs that conflict with Western medicine? Our job isn't to judge, it's to understand and problem solve." That conversation had changed how I approached every patient interaction. Instead of seeing difficulties as character flaws, I started seeing them as puzzles to solve, as opportunities to understand the whole person rather than just treating the disease. The shift started routinely enough. I'd admitted 2 patients from the ED, an elderly man with pneumonia who needed IV antibiotics, and a middle-aged woman with a diabetic ulcer that had become infected. I'd written admission orders, documented histories and physicals, and coordinated with consultants. Around 11 p.m., I'd responded to a page about Mr. Chen in room 437, whose blood pressure had dropped. We'd given IV fluids and adjusted his medications, and he'd stabilized quickly. His nurse, Gloria, had thanked me for coming so promptly. "Lots of residents take their time responding to pages," she'd said. "Nice to work with someone who takes nursing concerns seriously." The comment had meant more to me than she probably realized. I'd learned early that nurses were invaluable allies. They spent far more time with patients than doctors did, often caught problems before they became critical, and had institutional knowledge that no medical textbook could provide. Around 1 a.m., I'd been called to see Mrs. Rodriguez, whose pain medication wasn't controlling her discomfort after hip surgery. She'd been crying quietly when I entered her room, embarrassed to be bothering anyone. "You're not bothering anyone," I'd assured her. "Pain control is important. Let's figure out how to make you more comfortable." We'd increased her dose and added a different class of pain reliever, and within 30 minutes, she'd relaxed into comfortable sleep. Her daughter, who'd been sitting vigil in the bedside chair, had squeezed my hand as I left. "Thank you for being kind to her," she'd whispered. "Some doctors make her feel like a burden for asking for help." Around 2 a.m., I'd grabbed terrible coffee from the physician's lounge and a granola bar from the vending machine, standing at the window overlooking the parking lot. Snow was falling lightly, accumulating on cars and sidewalks, transforming the mundane landscape into something almost beautiful in the sodium vapor lights. I'd been trying to decide if I had time to lie down in the call room for 20 minutes, maybe catch a quick nap before the next crisis. But something about the quiet felt fragile, temporary, like the calm before a storm. I'd learned to trust those instincts, the sixth sense that develops after enough night shifts when things go wrong. At 2:30 a.m., I'd done walking rounds, checking on the patients who couldn't sleep. Mr. Patterson, whose COPD made him anxious about lying flat. Mrs. Kim, whose new diagnosis of cancer kept her awake worrying about her grandchildren. Young Tommy Rodriguez, 17 years old with sickle cell crisis, trying to be brave but clearly in pain. I'd spent a few minutes with each, adjusting blankets, answering questions, providing the kind of small comforts that aren't really medicine but somehow matter just as much. My mother used to say that healing required not just skill but cariño, care, tenderness, the willingness to see the person, and not just the patient. That's when I'd met Catherine Morrison for the first time that night. She was in room 512, admitted earlier that evening with chest pain that had resolved in the ED. Her cardiac enzymes were mildly elevated. Troponin of 0.12, just above the normal cutoff of 0.04, suggesting possible cardiac injury. We were monitoring her overnight before deciding whether she needed cardiac catheterization in the morning. When I'd stopped by her room during rounds, she'd been awake, reading a bridal magazine by the dim light over her bed. Her roommate, an elderly woman with pneumonia, was sleeping soundly in the other bed, breathing with the quiet rasp of someone whose lungs weren't quite working right. "Can't sleep?" I'd asked softly from the doorway, not wanting to disturb the roommate. Catherine had looked up and smiled, a warm, genuine expression that transformed her face from merely pleasant to genuinely beautiful. Too excited. My daughter's getting married next month, and I'm helping plan everything. I keep thinking of details I need to remember. I'd stepped into the room, keeping my voice low. "Tell me about it. Sometimes talking helps." And she had. For 15 minutes, Catherine Morrison had told me about her daughter Emily, 26 years old, marrying her college sweetheart James, about how they'd met in a chemistry class, bonding over their shared confusion about organic molecules, about the proposal James had planned, a scavenger hunt through all the places that had been meaningful in their relationship, ending at the botanical garden where he'd gotten down on one knee surrounded by roses. "I cried for an hour," Catherine had said, laughing at the memory. Emily kept trying to console me, saying, "Mom, this is supposed to be happy," but I couldn't stop. Happy tears, sad tears, all mixed together. Because on one hand, I'm thrilled for her. James is wonderful, kind, funny, ambitious, but not in an arrogant way. He treats her like she's precious. But on the other hand, my baby is getting married. When did she grow up? It feels like yesterday I was teaching her to tie her shoes. I'd smiled, understanding something of what she meant. My own mother had cried when I'd left for college, then again when I'd left for medical school, each milestone both proud and painful. Catherine had told me about the venue they'd chosen, a historic mansion with gardens built in the 1890s and preserved as a heritage site. About the dress Emily had picked, vintage lace with pearl buttons down the back, elegant and timeless. About the menu, which had taken weeks to finalize because Emily wanted to accommodate all her friends' dietary restrictions. About the flowers, peonies and roses in blush pink and cream. About the music, a string quartet for the ceremony, a DJ for the reception. "I just want everything to be perfect," she'd said, her eyes bright with joy and anticipation. "Emily's our only child, and she deserves a perfect day. No stress, no problems, just pure happiness. I'm sure it will be beautiful," I'd said. "And I'm sure having you there, healthy and happy, is what matters most to her." Catherine had nodded, but her expression had shifted, shadows crossing her face. "That's why I came to the hospital tonight. The chest pain scared me. I kept thinking, what if something happens to me before the wedding? What if I'm not there to see her walk down the aisle? What if I miss the most important day of her life?" "That's not silly at all," I'd reassured her. "It's completely understandable, and we're keeping you overnight precisely so we can make sure you're okay. Better to be cautious and rule out anything serious." The ER doctor said my heart enzymes were barely elevated. He seemed to think it was probably nothing major. "Even small elevations matter," I'd explained. "They tell us that some heart muscle cells were damaged, even if only a few. We need to figure out why that happened and make sure it doesn't happen again. You'll see a cardiologist in the morning, and they'll help us make a plan." She'd seemed reassured by this, settling back against her pillows. "Will you be here in the morning, when the cardiologist comes?" "I'm here all night, and I'll check on you again before my shift ends at 7 a.m. If anything changes, anything at all, I'm just a page away. But try to get some sleep. Your body needs rest to heal, and you need energy for all that wedding planning." Catherine had laughed softly. "You're very kind, Dr. Reyes. How old are you, if you don't mind me asking?" 27. "My goodness. You're the same age as Emily. And here you are, a doctor, taking care of people in the middle of the night. Your parents must be incredibly proud." "They are," I'd said, feeling the familiar warmth and weight of that pride. "They sacrificed a lot to give me opportunities they never had." "Well, their sacrifice was worth it. You have a wonderful bedside manner. Not all doctors do, especially young ones. You actually listen, and you treat patients like people instead of just medical problems to solve." The compliment had touched me more than I wanted to admit. "Thank you. That means a lot. Now go take care of your other patients, and thank you for letting me talk about the wedding. It helped settle my mind." I'd left her room feeling good about the interaction, about providing comfort and reassurance, about the human connection that makes medicine meaningful beyond the technical aspects. That was 45 minutes ago. Now Catherine Morrison's heart has stopped, and all the wedding planning in the world means nothing if I can't bring her back. The code team arrives in a controlled rush, organized chaos perfected through countless repetitions. Lisa Chen, the senior night nurse, wheels in the crash cart, its drawers filled with medications and equipment for every emergency scenario. Behind her comes David Park, a second-year resident who's faster and more experienced than me, and Maria Santos, the respiratory therapist who will manage Catherine's airway. "What do we have?" David asks, already moving to the opposite side of the bed, ready to take over compressions when I need a break. I give him the essential information while maintaining my compression rhythm. 52-year-old female, admitted for chest pain and troponin elevation. Troponin was 0. 12 on admission, trending upward. Was stable all evening, talking to me normally 30 minutes ago. I came back to check on her and found her unresponsive with no pulse. Monitor showed a systole. I started CPR immediately. I've been doing compressions for about 90 seconds. Good response time. Any witnessed events? Did she complain of pain or shortness of breath before the arrest? Not that I know of. Her roommate is sleeping. I haven't woken her to ask. The last time I saw the patient about 45 minutes ago, she was comfortable reading a magazine, excited about her daughter's upcoming wedding. David nods, processing this rapidly. So likely acute coronary event. Either extension of her earlier MI or a new thrombosis. Okay, switch with me. You've been going for 90 seconds. Time for fresh hands. We switch positions smoothly. A practiced exchange that minimizes the interruption to compressions. David takes over the chest compressions while I move to the head of the bed, where Maria is already setting up the intubation equipment. "Airway's patent," Maria reports, placing her hand on Catherine's forehead and tilting it back slightly to open the airway. "I'll bag her for now with the mask. If this goes longer than a few minutes, we'll need to intubate for better airway protection." Lisa is drawing up medications, her hands moving with practiced efficiency born of running hundreds of codes. She's been a nurse at St. Halstead for 20 years, has seen everything, and has a preternatural calm during emergencies that steadies everyone around her. "First dose of epi?" she asks, looking at me for confirmation. I check my watch, calculating the time since arrest. It's been 2 minutes since I found Catherine unresponsive. "Yes, 1 milligram IV push." She injects the epinephrine through the IV port, adrenaline designed to stimulate the heart, to shock it back into producing electrical activity, to give us any kind of rhythm to work with. We wait. Watch the monitor with collective held breath. Still flatline. The green line remains horizontal, unbroken, lifeless. David continues compressions, his technique textbook perfect. Elbows locked, shoulders positioned directly over Catherine's chest, compressions at least 2 inches deep, delivered at a rate of 100 to 120 per minute. I can hear him counting under his breath, maintaining the rhythm that might keep Catherine's brain alive. "Any shockable rhythm?" Lisa asks, checking the defibrillator settings. "No," I confirm, studying the monitor. A systole isn't shockable. We continue CPR, administer medications according to protocol, and try to identify reversible causes. This is the algorithmic part of running a code, following the ACLS protocols established through decades of research and refinement. But protocols only take you so far. There's an art to resuscitation, a clinical judgment about when to follow the algorithm strictly and when to adapt based on the specific patient and circumstances. "Give me her history," David says between compressions. "Previous cardiac issues, surgeries, current medications, anything that might tell us what we're dealing with?" I pull up Catherine's chart on the computer mounted on the wall, scanning quickly through the information. No significant cardiac history. Had a hysterectomy 10 years ago for fibroids, but otherwise no major medical issues. On lisinopril for mild hypertension, 10 milligrams daily, and atorvastatin 40 milligrams for cholesterol. Those are her only regular medications. No drug allergies documented. So, previously healthy woman with new onset chest pain and now arrested. What brought her in tonight specifically? Chest pain started around 6 p.m. Substernal, described as pressure-like, radiating to her left arm and jaw. Classic cardiac distribution. Lasted about an hour, then spontaneously resolved. She came to the ED around 8 p.m. Initial troponin was 0.08, just barely above our lab's cutoff of 0.04. They repeated it at midnight and it had risen to 0.12. EKG showed some ST depressions in the lateral leads, but nothing dramatic. David processes this while maintaining his compression rhythm. So NSTEMI, non-ST elevation myocardial infarction. Small heart attack, but now she's arrested. Either the infarct extended significantly, or she developed a fatal arrhythmia, or she threw a massive pulmonary embolus. The fact that she went straight to asystole instead of VFib suggests either extensive cardiac damage or a massive PE. That's my thinking too. 3 minutes, Lisa announces, watching the code timer on the wall. Second dose epi, I order. She pushes another milligram of epinephrine. We watch the monitor, hoping for any change, any flicker of electrical activity. Nothing. The line remains flat, accusatory in its emptiness. I'm running through the reversible causes of cardiac arrest in my head, the H's and T's that every medical student memorizes. Hypovolemia, hypoxia, hydrogen ions, acidosis, hyperkalemia, hypothermia, tension, pneumothorax, cardiac tamponade, toxins, thrombosis, pulmonary or coronary. Breath sounds? I ask Maria. She listens with her stethoscope, placing it on both sides of Catherine's chest while David pauses compressions briefly. Equal bilaterally. Good air entry. No pneumothorax. Jugular veins? Lisa checks Catherine's neck. Flat. Not distended. Unlikely to be tamponade. These are the quick assessments we can make bedside, ruling out causes that would require immediate specific interventions. No tension pneumothorax that would need needle decompression. No cardiac tamponade that would need pericardiocentesis. We restart compressions immediately. Every second without blood flow means brain cells dying, organs failing, the window of possible recovery narrowing. 5 minutes, Lisa says quietly. Third dose epi. The medication goes in like all the others before it. And like all the others, it produces no visible change on the cardiac monitor. Still flat. Still death displayed in a green line across a black screen. Dr. Marcus Webb arrives at 6 minutes, having been called by the automated code alert system that pages all attendings when a code blue is called. He's wearing jeans and a university sweatshirt, clearly dressed in whatever was closest when his phone woke him. But his eyes are sharp, alert, focused. Status? He asks, moving to the foot of the bed where he can see everything. The patient, the monitor, the team working, the organized chaos of resuscitation. I give him a rapid but complete summary. Patient demographics, reason for admission, timeline of events leading to arrest, interventions we've performed so far, current rhythm and assessment of possible causes. He listens without interrupting, then asks the question that cuts to the heart of every code, the question that separates algorithmic medicine from clinical medicine. Noah, what do you think is going on here? Not what does the protocol say, but what story is this patient's body telling you? I take a breath, organizing my thoughts even as David continues compressions, and Lisa draws up the next dose of medication. I think she had a small myocardial infarction earlier today, probably a partial occlusion of one of her coronary arteries. The chest pain, the troponin elevation, the EKG changes all support that. She was stable for hours, talking normally, neurologically intact. But something changed in the last hour. Either the partial occlusion became complete, causing a massive extension of her infarct, or she developed a lethal arrhythmia secondary to the ischemic tissue, or possibly she threw a clot, either coronary or pulmonary. Why asystole instead of a shockable rhythm? That's what worries me. VFib or VTASH would suggest ischemic myocardium that's irritable, electrically unstable, but asystole suggests either complete electrical failure, meaning massive tissue damage to the conduction system, or a mechanical problem like a massive PE or cardiac rupture. Dr. Webb nods slowly. Good clinical reasoning. So, given that assessment, what would you like to do? The question is both empowering and terrifying. He's not taking over, not issuing orders. He's trusting my judgment, treating me as a colleague rather than a student, while remaining present if I need guidance or if my judgment proves flawed. I want to continue the code, I say firmly. She's 52 years old. She was completely healthy and functional 30 minutes ago. She has a daughter getting married next month. I'm not ready to give up on her. Time frame? ACLS guidelines suggest we can reasonably continue for 20 minutes or more, especially if there are potentially reversible causes. I'd like to run this to at least 20 minutes unless something changes that suggests futility. Agreed. But Noah, what's the longest you've ever run a code? The question brings me up short. 15 minutes. In simulation during ACLS certification. This is now at 7 minutes. Real codes are different from simulation. They're physically exhausting. You'll need to rotate compression duties frequently to maintain quality. They're emotionally draining. You'll start second-guessing every decision. And they're long. 20 minutes feels like an eternity when you're watching someone die despite your best efforts. His words are honest without being discouraging, realistic without being defeatist. I understand. Good. Then this is your code. You're the team leader. I'm here to observe and advise if needed, but the decisions are yours. And Noah, you're doing well. Your initial management has been textbook. Keep going. At 10 minutes, I'm beginning to understand what Dr. Webb meant about the difference between simulation and reality. The physical exhaustion is profound. Even though we rotate compressions every 2 minutes, David, then Maria, then me, then back to David, the act of pushing hard and fast on someone's chest for 2-minute intervals is brutally demanding work. My shoulders burn. My hands are cramping from maintaining proper position. Sweat drips down my back despite the cool temperature of the hospital room, but the mental exhaustion is worse. Every medication I order, I'm calculating dosages, considering timing, watching for side effects. Every intervention I contemplate, I'm weighing risks and benefits with incomplete information. Every second that passes, I'm asking myself if we're helping or just prolonging the inevitable, if I'm fighting appropriately or foolishly, if my determination to save Catherine is medical judgment or emotional attachment. 10 minutes, Lisa announces, her voice steady but carrying an undertone of concern. 5th dose, epi. The epinephrine goes in through the IV, our 5th milligram in 10 minutes. Enough adrenaline to make a healthy person's heart race uncontrollably, but doing nothing for Catherine's still heart. David continues compressions, his face set in concentration, his technique still perfect despite obvious fatigue. Maria bags rhythmically, squeezing the bag valve mask every 5 seconds, forcing oxygen into lungs that aren't properly exchanging it, into blood that isn't circulating adequately, into a brain that's being starved cell by cell. Should we intubate? Maria asks, a reasonable question given the duration of the code. I can keep bagging, but a definitive airway might give us better oxygenation and ventilation. I consider this carefully. Intubation would give us a secure airway, allow us to control Catherine's breathing more precisely, free up Maria to help with other tasks. But it would require stopping compressions for at least 30 to 60 seconds while we place the tube, 30 to 60 seconds without any blood flow to Catherine's brain. The calculation is brutal. Is the benefit of a better airway worth the cost of interrupted compressions? Not yet, I decide. Your bagging is effective. I can see good chest rise. Her oxygen saturation is reading 94% when we check between compression cycles. Let's not interrupt compressions unless we absolutely have to. Doctor. Webb nods approvingly from his position near the wall, where he's been observing without interfering. Any change on the monitor? I ask, though I can see the screen myself. Lisa shakes her head. Still a systole. Flatline. I do another mental run through the H's and T's, looking for something we've missed, some reversible cause we can address. We've ruled out tension pneumothorax. Breath sounds are equal. We've ruled out cardiac tamponade. Jugular veins aren't distended. We're addressing hypoxia with oxygen. We've given epinephrine for cardiac stimulation. What are we missing? Did we get labs when she was admitted? I ask. Complete metabolic panel? Lisa pulls up the chart on the computer. Yes, sodium 139, potassium 4.2, chloride 103, bicarb 24, bun 16, creatinine 0.9, glucose 102. All normal. So not hyperkalemia causing cardiac arrest, not profound acidosis or metabolic derangement. Could this be a massive PE? David asks between compressions, voicing the thought that's been nagging at me. Pulmonary embolism that caused the arrest? The chest pain earlier could have been from a clot, not necessarily cardiac ischemia. It's a reasonable consideration. Pulmonary embolism can present with chest pain, can cause troponin elevation from right heart strain, and can cause sudden cardiac arrest if the clot is large enough to completely obstruct pulmonary blood flow. Possible, I acknowledge, but our management doesn't fundamentally change. If it's a PE, we continue CPR in the hope that our compressions break up the clot or move it enough to restore some perfusion. We can't give thrombolytics during active CPR because the bleeding risk is too high. What about empiric thrombolytics? Dr. Webb suggests quietly. Not standard protocol, but if you suspect massive PE as the cause, there's literature supporting TPA administration during prolonged codes. I consider this tissue plasminogen activator. a clot-busting medication that could dissolve a pulmonary embolus, but carries significant bleeding risks, especially after prolonged CPR when we've likely already caused internal trauma from chest compressions. I want to hold that in reserve, I decide. If we get to 15 or 18 minutes with no response, I'll consider it. But for now, let's continue standard ACLS protocol. Reasonable, Dr. Webb confirms. 12 minutes, Lisa says, and I hear the slight change in her tone, the shift from hopeful to concerned that happens when codes stretch past the usual duration. 6th dose epi. The medication is pushed. The compressions continue. The monitor remains unchanged. I glance at Catherine's face, and the reality of the situation hits me with renewed force. This isn't a mannequin or a simulation scenario. This is a real person, a mother excited about her daughter's wedding, a woman who was reading bridal magazines 45 minutes ago, a human being whose life is slipping away despite everything we're doing. Her skin has taken on a waxy appearance, pale and slightly gray. Her lips are faintly blue despite the oxygen. Her eyes are closed, her body completely limp. If you didn't see the organized chaos around her, the people doing compressions, pushing medications, monitoring rhythms, she could be sleeping peacefully, except sleeping people have heartbeats. I think about Emily, Catherine's daughter, probably asleep right now in her own home or apartment, dreaming about wedding flowers and guest lists, completely unaware that her mother is dying in a hospital room while strangers fight desperately to save her. Who will call Emily when this is over? What will we say? Your mother's heart stopped. We did CPR for 20 minutes. We gave her medications. We tried everything, but it wasn't enough. She's gone. I'm so sorry. How do you tell someone that their mother died the month before their wedding? How do you explain that the woman who should be walking her down the aisle, who should be in the front row crying happy tears, who should be dancing at the reception, how do you explain that she's gone? Noah. Dr. Webb's voice cuts through my spiraling thoughts, firm but gentle. Stay present. Don't go down that road yet. Focus on what you can control right now. He can read my face, see the emotional descent happening alongside the clinical crisis. And he's right. Catastrophizing about outcomes I can't control won't help Catherine. I need to stay focused, stay systematic, stay present. Right, staying present. Talk to your team, Dr. Webb coaches. Keep them engaged. Long codes require mental and physical stamina from everyone, and clear communication helps maintain focus. I nod, then address the group working around Catherine's bed. We're at 12 minutes. Everyone is doing excellent work. David, your compressions are textbook, consistent depth and rate. Maria, your ventilation is perfect. Lisa, your medication timing and documentation are flawless. We're going to keep going. We're going to give Mrs. Morrison every possible chance. Dr. Webb, anything you'd add? One thought, he says, moving slightly closer to the bed. Noah, pull up her initial EKG from the ED again. I want to look at something. I navigate to the EKG in the computer system and pull it up on the monitor. The 12-lead tracing shows the electrical activity of Catherine's heart from 6 hours ago. Subtle ST depressions in leads V4, V5, and V6. The lateral leads, concerning for cardiac ischemia, but not diagnostic of a massive acute MI. Dr. Webb studies it carefully. Look at the PR interval and the QRS morphology. I look more closely. The PR interval, the time between atrial and ventricular activation, seems slightly prolonged, and the QRS complexes have a slightly abnormal shape. What am I seeing? I ask. Subtle signs of conduction system disease. This wasn't just ischemia to heart muscle. There was involvement of the electrical system even then. Noah, I want you to consider the possibility that Mrs. Morrison has had a massive anterior wall MI that's now completely disrupted her conduction system. If the left anterior descending artery is occluded and the infarct has extended into the septum where the conduction pathways run, we might be dealing with a heart that physically cannot generate electrical activity anymore. The implication settles over me like a heavy weight. He's suggesting that we might be doing CPR on a heart that's already electrically dead, that no amount of compressions or medications will revive, because the tissue responsible for generating and conducting electrical impulses is gone, destroyed by lack of blood flow. If that's true, what are our options? Limited, Dr. Webb admits. The only definitive treatment would be emergent revascularization, opening the occluded artery with angioplasty and stenting. But even that might not help if the damage is already done. Is there a cath team available? Lisa is already on the phone, calling the interventional cardiology service. After a brief conversation, she hangs up and shakes her head. The on-call team is coming in, but they're scattered. The attending is 30 minutes away. One of the techs is 45 minutes out. Even once they arrive, it'll take at least 20 minutes to set up the cath lab. We're looking at an hour minimum before we could get her to the table. An hour. We're at 13 minutes now. Can we keep doing CPR for 73 minutes? 13 minutes, Lisa announces. 7th dose epi. The medication goes in like all the others. And like all the others, it produces no visible change on the monitor. Still flat. Still death displayed in an unbroken green line. Still a woman who should be planning her daughter's wedding. Now a body we're mechanically maintaining with external chest compressions and artificial ventilation. Rhythm check, I call out, following protocol. David stops compressions. We all look at the monitor, searching for any sign of electrical activity, any hint that Catherine's heart is trying to restart itself. Nothing. Complete electrical silence. Not even the disorganized quivering of ventricular fibrillation. Just flat, empty asystole. Resume compressions. David starts again immediately, but I can see the fatigue in his face, the slight slowing of his rhythm despite his best efforts. Switch, I order. Maria, can you take over? David, you take over bagging. Let's keep rotating. Fresh hands every 2 minutes. We switch positions in a practiced rotation, minimizing interruption to compressions. Maria's technique is just as good as David's, and having rested hands means the quality doesn't deteriorate. 15 minutes, Lisa says quietly, and I hear the unspoken question in her voice. How much longer? 15 minutes of CPR. 15 minutes of a heart that refuses to restart. 15 minutes of fighting against death with nothing but our hands and medications and desperate, dwindling hope. I make eye contact with Dr. Webb across the bed. He raises his eyebrows slightly. A wordless question. How much longer are you going to push this? When will you accept that we've done enough? I don't have an answer. I just know I'm not ready to stop. Not yet. 8th dose epi, I order. My voice firmer than I feel. And let's get a point-of-care ultrasound in here. I want to visualize the heart directly. See if there's any mechanical activity that the monitor isn't picking up. Lisa pages the ultrasound tech while pushing the epinephrine. Within 3 minutes, a portable ultrasound machine is wheeled into the room by a sleepy-looking tech who's clearly been called in from home. I need to see cardiac function, I tell her, during a brief pause in compressions. She nods, professional despite the ungodly hour, and positions the ultrasound probe. I call for another rhythm check. Compressions stop, and she places the probe on Catherine's chest in the subcostal position, angling it toward her heart. The image appears on the small screen, grainy but clear enough. I've seen beating hearts on ultrasound before during my training. The miraculous flutter of valves opening and closing, chambers contracting and filling, blood swirling through ventricles and atria, the visual proof of life captured in black and white on a screen. This is not that. Catherine's heart is visible in the ultrasound image. I can see the outline of the ventricles, the walls of the chambers, the shadows of the valves. But there's no movement. None. Not even a weak flutter or quiver of contractile effort. Just a completely still organ that used to pump blood through her body, that used to respond to electrical signals with coordinated mechanical contractions. Now it's just stopped, motionless, dead tissue being compressed externally by our hands, but not generating any intrinsic activity of its own. Resume compressions, I say, my voice suddenly heavy with the weight of what I've just seen. Because this changes things. The flat line on a monitor could be artifact, could be a lead malfunction, could be a technical issue with the electrical recording. But the actual heart, visualized directly with ultrasound, showing no motion at all, that's different. That's objective evidence that Catherine's heart is not just electrically silent, but mechanically inert. 17 minutes, Lisa says, and I hear the shift in her voice, from concern to something approaching hopeless. I'm doing compressions again. My third rotation, my arms burning with accumulated lactic acid, my shoulders screaming in protest. But I keep pushing, maintaining the rhythm, because stopping means death, and I'm not ready to accept that yet. Dr. Webb steps closer to the bed, his voice low enough that only I can hear. Noah, I think we need to have a conversation about stopping. The words hit me like a physical blow, even though I knew they were coming. Dr. Webb, I know. Believe me, I know how hard this is. But we're at 17 minutes of continuous asystole. We've given 8 doses of epinephrine with no response. We've maintained high-quality CPR throughout. The ultrasound showed no cardiac activity at all, not even a flicker. And even if we somehow achieved return of spontaneous circulation at this point, The amount of time Mrs. Morrison's brain has been without adequate perfusion makes meaningful neurological recovery extremely unlikely. She was talking to me 45 minutes ago, I say, my voice tight. She was excited about her daughter's wedding. She has a family waiting for her. She's 52 years old. She should have decades left. I agree with all of that, Dr. Webb says gently. And that makes this harder, not easier. It's always harder when the patient is young, when they were healthy before, when you've connected with them as a person. But Noah, part of being a physician is recognizing when we're helping and when we're just inflicting trauma on a body that's already gone. I want to argue. I want to cite statistics about miraculous recoveries, about patients who were resuscitated after 30 or 40 minutes and walked out of the hospital neurologically intact. I want to tell him about Emily and the wedding dress with pearl buttons and how Catherine deserves to walk her daughter down the aisle. But deep down, beneath the desperation and the determination, I know he's right. The ultrasound showed no cardiac activity. The monitor has shown flat asystole for 17 minutes. We've given every medication, performed every intervention, ruled out every reversible cause we can address. And Catherine's heart is not responding. At some point, continuing CPR transitions from life-saving intervention to denial of death, and I'm terrified that we've already crossed that line. How long? I ask, my voice barely above a whisper. How long do we keep going? That's your call to make. You're running this code. But Noah, I would say another 2 to 3 minutes. 20 minutes total is very reasonable for asystole with this presentation. Beyond that, we're past the point where meaningful recovery is realistic. I nod slowly, feeling the weight of the decision settling onto my shoulders. Okay, we run this to 20 minutes. Then we stop. That's appropriate and compassionate for Mrs. Morrison and for her family. I look at my team, David, Maria, Lisa, all of them showing obvious signs of exhaustion, but still working with focused determination. Listen up, I say, my voice steadier than I feel. We're going to continue this code to 20 minutes. That gives us 3 more minutes. I want perfect CPR for these last 3 minutes. Optimal compressions, optimal ventilation, 1 final dose of epinephrine. We're going to give Mrs. Morrison every possible chance we can offer her. They nod, understanding the subtext. These are the final minutes, the last chance, the end of the line. 9th dose epi, I order. Lisa draws it up and pushes it through the IV. Maria continues compressions, her face set with concentration and something that might be grief. The room falls into a different kind of quiet. No longer the frantic energy of early resuscitation, but a more solemn determination. We're no longer fighting to save Catherine. We're honoring her, bearing witness to her passing, ensuring that every possible effort was made so her family can know she wasn't abandoned, wasn't given up on easily. 18 minutes. I watch the monitor, knowing intellectually that it won't change but unable to stop hoping for a miracle. The flat green line feels accusatory, a visual representation of failure, and I start the cycle of second-guessing that Dr. Webb warned me about. Should I have checked on Catherine more frequently during the night? Should I have insisted on an immediate cardiology consult when I saw her at 2:30 a.m. instead of waiting for morning? Should I have recognized something in her presentation that would have predicted this catastrophic event? Noah, Dr. Webb's voice again, reading my face like a book. Don't do that to yourself. You did not fail this patient. Sometimes cardiac arrests happen despite perfect care. Nothing in Mrs. Morrison's presentation suggested she was about to arrest. Her vital signs were stable. Her symptoms had resolved. You did everything right. It doesn't feel like I did everything right. I know. That feeling doesn't go away. You just learn to carry it differently. You learn to distinguish between mistakes you made and outcomes you couldn't prevent. This is the latter. How do you know? Experience. And trust me when I tell you that in your career, you will have patients who die because of mistakes you made. This isn't one of them. This is just the brutal reality that sometimes people die despite our best efforts. 19 minutes. Maria's compressions are slowing slightly, exhaustion finally overwhelming technique. I step in to relieve her. I'll finish the last minute. I position my hands on Catherine's chest one final time, heel of my right hand on the center of her sternum, left hand on top, fingers interlaced, elbows locked. I start compressions again, resuming the rhythm that has kept some minimal circulation going for 19 minutes. 1, 2, 3, 4. This is it. The last minute. The final chance before we admit defeat and declare time of death. 10, 11, 12. I think about Catherine's daughter, Emily. About the phone call I'm going to have to make in a few minutes, explaining that her mother coded, that we did everything possible, that she didn't survive. About how Emily's wedding planning will transform from joyful anticipation to grief-shadowed going through the motions. 20, 21, 22. I think about the empty seat at the wedding where Catherine should have been. About Emily walking down the aisle without her mother's hand to hold. About all the moments Catherine will miss, grandchildren she'll never meet, holidays she won't celebrate, the ordinary accumulation of days that make up a life. 28, 29, 30, and then, impossibly, I feel something. Not much. Not the strong, coordinated contraction of a healthy heart. Just the faintest flutter beneath my hands. A subtle change in the resistance, like the difference between pressing on an inanimate object and pressing on something that has just the tiniest hint of responsiveness. I pause, uncertain if I actually felt it or if it was wishful thinking, desperate hope manifesting as tactile hallucination. Wait, I say. I think I felt something. Rhythm check, Dr. Webb orders immediately, his voice sharp with sudden attention. I stop compressions. We all turn to stare at the monitor, holding our collective breath, barely daring to hope. For 3 seconds, the line remains flat, the same endless green horizontal that has mocked us for 19 minutes. Then, there, a single, tiny blip. A brief deflection in the line, gone so quickly I almost think I imagined it. Then another blip, slightly larger this time. Then another. "She's got a rhythm!" Lisa shouts, her voice cracking with surprise and relief. I'm seeing complexes. Narrow. Regular. Rate is about 40. I grab my stethoscope with shaking hands and place it on Catherine's chest. And there it is. Faint, slow, barely audible but unmistakable. A heartbeat. Lub-dub, lub-dub, lub-dub. The most beautiful sound I've ever heard. Check for pulses, Dr. Webb orders, his own voice tight with controlled emotion. I move my fingers to Catherine's carotid artery, pressing gently into the soft tissue of her neck. And I feel it. Weak, thready, but present. A pulse, blood flowing, a heart beating. Life where 30 seconds ago there was death. "I've got pulses!" I announce, my voice breaking with emotion I can't contain. Weak, but present. The room erupts in controlled chaos, everyone moving simultaneously, rechecking vital signs, adjusting monitors, preparing for whatever comes next. The mood shifts instantly from solemn resignation to urgent hope. "Blood pressure?" Dr. Webb asks. Lisa triggers the automatic cuff. We wait while it inflates, deflates, calculates. 78/42, low, but present. Start a vasopressor drip, no epinephrine, titrate to maintain systolic above 90, and get an ICU bed ready immediately. She needs intensive monitoring, and we need to figure out what caused this arrest and prevent it from happening again. Orders fly. Medications are drawn up and administered. Phone calls are made. The machinery of critical care medicine kicks into high gear now that we have a living patient instead of a body. I'm still holding my stethoscope to Catherine's chest, listening to that miraculous sound, barely able to believe it's real. Her heart, 20 minutes after it stopped, after we'd visualized it motionless on ultrasound, after I'd been preparing to call time of death, her heart is beating again. "Is she responsive?" Maria asks. The question we're all thinking. I do a rapid neurological assessment. Catherine's eyes are closed. She doesn't open them when I call her name. But when I apply firm pressure to her fingernail bed, a painful stimulus, she grimaces slightly and her hand pulls away. "She's got purposeful response to pain," I report, hardly daring to hope what that might mean. "GCS is probably around 6 or 7. "That's actually encouraging," Dr. Webb says, and I hear genuine surprise in his voice. Considering she had 19 minutes of downtime with only CPR-level circulation, any neurological response at all is remarkable. It suggests her brain wasn't completely deprived of oxygen, that our compressions were effective enough to maintain some minimal perfusion. We work for the next 20 minutes getting Catherine stabilized enough for transfer. The vasopressor drip is titrated to support her blood pressure. She's intubated to protect her airway since she's not conscious enough to protect it herself. Additional IV lines are placed. Labs are drawn to assess the damage from the arrest and guide further treatment. An arterial line is inserted for continuous blood pressure monitoring. Finally, she's stable enough, or as stable as she's going to get, for transport to the ICU. As the team prepares to wheel her bed out of the room, As they carefully organize all the IV poles and monitor cables and ventilator tubing, I stand back and just look at her. She's alive. Against all odds, against my own mounting certainty that we were going to lose her, against the flat line on the monitor and the motionless heart on ultrasound. She's alive. Her chest rises and falls with the ventilator's rhythm. The monitor shows a heart rate of 52, a blood pressure of 94/48 with medication support. The pulse oximeter reads 96% oxygen saturation. Numbers that mean life. Dr. Webb puts his hand on my shoulder as the team wheels Catherine toward the ICU. You brought her back, Noah. 19 minutes of asystole, and you brought her back. That was extraordinary work. But I don't feel triumphant. I feel exhausted, shaky, emotionally wrung out, and I'm acutely aware that we've won a battle, but the war is far from over. Catherine has a heartbeat again, yes. But what will her neurological status be when she wakes up? Will she wake up? Will she be herself? Or will she have suffered catastrophic brain damage that leaves her alive but not truly living? And if she does wake up, if she is herself, will her heart survive? Will we figure out what caused the arrest and fix it? Or will this happen again? What are her chances? I ask quietly. Dr. Webb is silent for a moment, choosing his words carefully. Better than they were an hour ago. Much better. The return of spontaneous circulation is huge. It's the difference between life and death. The fact that she has some neurological responsiveness is encouraging. It suggests that our CPR was effective enough to maintain minimal brain perfusion throughout the code. But she's not out of the woods, not by a long shot. The next 24 to 72 hours are critical. Her heart could arrest again if we don't identify and treat the underlying cause. She could develop complications: pneumonia from aspiration during the code, acute kidney injury from low blood flow, multi-organ failure. And we won't know the full extent of any neurological damage until she wakes up and we can assess her properly. And if she survives all that, then you'll have saved a life, Noah. You'll have given a woman the chance to walk her daughter down the aisle, to meet her grandchildren, to live the rest of her natural life. And you'll have learned something invaluable about perseverance, about trusting your instincts, about knowing when to push past the guidelines and keep fighting. He pauses, making sure I'm listening. But you'll also have learned that even when we win, even when we bring someone back from death, it's rarely clean or simple or certain. Medicine isn't like the movies where the patient goes into cardiac arrest. We shock them once, and they wake up thanking us. It's messy and complicated and uncertain, and the outcomes are often somewhere in the gray area between complete success and total failure. I absorb his words, understanding that this is another lesson, maybe the most important lesson of the night, that in medicine, victories are rarely absolute. That saving someone's life is just the beginning, not the end. That every patient who survives carries forward both the miracle of their continued existence and the scars of what brought them so close to death. Catherine Morrison spent 6 days in the ICU. The first 48 hours were precarious. Her heart remained weak and unstable, requiring continuous vasopressor medications to maintain adequate blood pressure. We titrated her norepinephrine carefully, trying to find the balance between supporting her circulation and not overworking her damaged heart. Her cardiac enzymes came back drastically elevated. Troponin peaked at 45, more than 1,000 times the normal level, confirming that she'd suffered a massive myocardial infarction. Cardiology performed an emergency cardiac catheterization on the morning after her arrest. They found a complete occlusion of her left anterior descending artery, the Widowmaker lesion, so named because of its high mortality rate. The artery had likely been partially blocked for weeks or months, with the final complete occlusion happening sometime during the night. They opened the vessel with angioplasty, placed 2 stents, and restored blood flow to the affected area of her heart muscle. But the damage was already done. The ultrasound of her heart showed severely reduced function. Her ejection fraction was only 25%, meaning her heart was pumping less than 1/3 of the blood volume it should with each beat. Large portions of her left ventricle weren't contracting at all, the muscle tissue dead from lack of oxygen during the hours before and during her cardiac arrest. Her lungs had been injured too, damaged by the prolonged CPR and the aspiration that likely occurred when she arrested. She needed aggressive ventilator support, high oxygen concentrations, and careful fluid management to keep her from developing pulmonary edema. Her kidneys showed signs of acute injury from the prolonged period of low blood flow. Her creatinine, a marker of kidney function, had risen from a normal 0.9 to 2.8, and she wasn't making much urine. The nephrology team was consulted, and we started her on continuous dialysis to support her kidneys while they recovered. But slowly, Incrementally, miraculously, she improved. On day 2, we were able to reduce her vasopressor medications. Her heart, though severely damaged, was generating enough output on its own to maintain adequate blood pressure with less pharmacological support. On day 3, her kidneys started recovering. Her creatinine began trending downward and her urine output increased. We were able to discontinue the dialysis. On day 3, we also successfully performed a spontaneous breathing trial, turning off the ventilator's support and letting her breathe through the tube on her own. She did well, maintaining good oxygen levels with minimal work, so we extubated her, removing the breathing tube and letting her breathe independently for the first time since the arrest. And on day 4, 4 days after her heart had stopped for 19 minutes, 4 days after I'd been preparing to call time of death, Catherine Morrison opened her eyes and recognized her daughter. I was there when it happened, doing my morning rounds in the ICU. Emily had been at her mother's bedside constantly, sleeping in the uncomfortable recliner chair, leaving only for brief trips to the bathroom or cafeteria. She looked exhausted, her hair unwashed, her eyes red-rimmed from crying and lack of sleep. "Any change?" I'd asked gently, not wanting to wake Catherine if she was sleeping. "She's been moving more," Emily had said hopefully. Her hands squeeze mine sometimes, and her eyes move under her eyelids, like she's dreaming. Those are good signs. They suggest her brain is active, processing, trying to wake up. But when will she actually wake up? When will I be able to talk to her? There's no way to predict exactly. Some patients wake up quickly after extubation. Others take days or even weeks. We just have to be patient and let her brain heal at its own pace. But even as I said it, Catherine's eyelids had fluttered. Then slowly, with visible effort, they opened. Her eyes were unfocused at first, moving randomly, not settling on anything. But then they found Emily's face and something shifted. Recognition, awareness, consciousness returning from wherever it had been for 4 days. "Mom?" Emily had whispered, leaning close. "Mom, can you hear me?" Catherine's lips moved, but no sound came out. Her throat was still raw from the breathing tube. She tried again, and this time a hoarse whisper emerged. "Emily?" Emily had burst into tears, grabbing her mother's hand. "Yes, Mom, it's me. You're in the hospital. You've been sick, but you're going to be okay. You're going to be okay." I'd backed out of the room quietly, giving them privacy for their reunion. My own eyes burning with tears I was too tired to hold back, because this was the outcome we'd fought for. This moment of recognition, of connection, of a mother and daughter reunited against impossible odds. Over the next 2 days, Catherine's neurological status continued to improve. She was able to speak in short sentences, though her voice remained hoarse. She was oriented to person and place, though her sense of time was understandably confused. She had no memory of the cardiac arrest itself. The last thing she remembered was reading her bridal magazine around 2:30 a.m., and then nothing until waking up in the ICU 4 days later. On day 5, I sat down with Catherine and Emily to explain what had happened. "Mrs. Morrison, do you remember me?" I asked gently. She studied my face, concentration evident in her expression. "You're Dr. Reyes? We talked about Emily's wedding?" "That's right. I'm so glad you remember that. Do you know what happened after our conversation?" She shook her head slowly. "Emily said my heart stopped?" "Yes. Around 3:15 in the morning, your heart stopped beating. You had what we call a cardiac arrest. I found you unresponsive and immediately started CPR while calling for help." "How long was I—" She couldn't finish the question. "Your heart wasn't beating for about 19 minutes. We did continuous CPR the entire time, and we gave you medications to try to restart your heart. At 19 minutes, just as we were preparing to stop our efforts, your heart spontaneously started beating again." Catherine's hand flew to her chest, as if she could feel the echo of that stopped heart. 19 minutes? That's impossible. People don't survive that long without a heartbeat. Most don't, I admitted. You're extremely lucky. The fact that we started CPR immediately, that we maintained high-quality compressions throughout, and that we didn't give up, all of that contributed to your survival. But there was also an element of fortune, of your body's resilience, that we can't fully explain. And my brain? Am I going to be okay? I feel fuzzy, confused sometimes. Your brain function is remarkably good considering what happened. You're oriented. You recognize people. You can communicate clearly. You will likely have some memory issues related to the arrest and the immediate aftermath. That's normal. And you might experience some cognitive fatigue for a while as your brain continues healing. But overall, Your neurological outcome is much better than we typically see in cases like yours." Emily squeezed her mother's hand. "What about her heart? The cardiologist said it was badly damaged." "It is," I confirmed, not wanting to sugarcoat the reality. "The cardiac catheterization showed that your mother had a complete blockage of one of her major coronary arteries. They opened it and placed stents, so blood is flowing again. But the muscle tissue that was starved of oxygen during the blockage and during the arrest has permanent damage. Your mother's heart function is significantly reduced. What does that mean for her future? It means she'll need medications, probably for life. Blood thinners to prevent clots, medications to help her heart pump more efficiently, medications to control blood pressure and cholesterol. She'll need regular cardiology follow-up. She'll need to make lifestyle changes, diet, exercise within her capacity, stress management, and she'll need to be vigilant about symptoms that might indicate her heart is struggling." Catherine's face fell. "Will I be able to live a normal life? Will I be able to see Emily get married?" And there it was, the question that mattered most to her, the fear that had brought her to the hospital in the first place. "Yes," I said firmly. "Your life will be different, and you'll have limitations you didn't have before. But with proper management and care, there's no reason you can't attend your daughter's wedding, see your future grandchildren, live many more years. You survived something that most people don't survive. What you do with that second chance is up to you." Catherine Morrison was discharged from the hospital on day 8. She was weak, had lost noticeable weight, moved slowly and carefully, but she was alive. She was herself. She could think, speak, recognize her loved ones, make decisions about her care. Her cardiologist had prescribed a complex medication regimen, aspirin and clopidogrel to prevent clots from forming in her stents, metoprolol to reduce her heart's workload, lisinopril to help her heart remodel, atorvastatin to prevent further cholesterol buildup, and spironolactone to reduce fluid retention. She had follow-up appointments scheduled, with cardiology in 1 week, with her primary care physician in 2 weeks, with cardiac rehabilitation to help her regain strength safely. And she had something else, a second chance at life that she'd nearly lost. On the morning of her discharge, I stopped by her room to say goodbye. She was dressed in her own clothes, yoga pants and a soft sweater, looking more like a person and less like a patient. "Dr. Reyes," she said when she saw me, her face brightening. "I wanted to thank you before I left." "You don't need to thank me. I was just doing my job." "No," she said firmly. "You saved my life. Emily told me that you kept doing CPR even when it seemed hopeless, even when other doctors might have stopped. You didn't give up on me." I didn't know what to say to that. I saw you as a person, not just a patient. You were excited about Emily's wedding. That mattered to me. Catherine reached out and took my hand. "I'm going to be at that wedding, Dr. Reyes. I'm going to walk my daughter down the aisle. I'm going to dance at the reception. I'm going to live to meet my grandchildren. And every single one of those moments will exist because you refused to let me die." She paused, emotion thick in her voice. "Thank you for those 19 minutes. Thank you for believing I was worth fighting for. Thank you for giving me a future I almost didn't have." I had to look away, blinking rapidly, my own eyes suddenly hot. "You're welcome. And Mrs. Morrison, enjoy every moment of that wedding. Celebrate life. That's the best thanks you can give me." 6 weeks after Catherine's cardiac arrest, an invitation arrived in my hospital mailbox. It was cream-colored cardstock with elegant script. "Emily Morrison and James Chen request the honor of your presence at their marriage," and at the bottom, a handwritten note in graceful cursive. "Dr. Reyes, please come. My mother insists, and I would be honored to have the man who saved her life witness our joy. Your presence would mean everything to our family. Emily." I stared at the invitation for a long time, uncertain. Was attending appropriate? Would it blur professional boundaries? Would it be presumptuous to show up at a patient's family event? But when I asked Dr. Webb's advice during rounds the next day, his response was immediate and unequivocal. "Go," he said. "Absolutely go. You earned the right to see the outcome of your work, and they clearly want you there." Sometimes we get so caught up in maintaining professional boundaries that we forget we're human beings having human connections. This is one of those moments where humanity matters more than protocol. So I went. The wedding was at a historic mansion with gardens, exactly as Catherine had described during our 2:30 a.m. conversation 6 weeks ago. It was late May, perfect spring weather, sunshine warm but not hot, a gentle breeze carrying the scent of blooming flowers. White chairs arranged on the lawn faced an archway covered in climbing roses. A string quartet played Pachelbel's Canon in D. I sat near the back, trying to be unobtrusive, still feeling somewhat out of place at this intimate family celebration. But other guests, recognizing me from the hospital or from Emily's descriptions, kept approaching to thank me, to shake my hand, to tell me how grateful they were. And then the music changed to Wagner's bridal chorus, and everyone stood. Emily appeared at the back of the aisle in her vintage lace dress with pearl buttons, looking radiant and nervous and beautiful. And beside her, walking slowly but steadily, dressed in an elegant navy blue dress, was Catherine Morrison. She'd lost weight since the arrest, looked more fragile than when I'd first met her. But she was there, smiling, crying happy tears, holding her daughter's arm as they walked together down the aisle between rows of guests, toward the altar where James waited. Halfway down the aisle, Catherine's eyes found mine in the crowd. Our gazes locked for just a moment, and she smiled, a brilliant, joyful expression of pure gratitude, and mouthed 2 words, "Thank you." I had to look away, my own vision blurring with tears I didn't try to hide, because this was it. This was why we do what we do. This moment, this mother walking her daughter down the aisle 6 weeks after her heart stopped for 19 minutes. This was the reason for all of it. The exhausting shifts, the impossible decisions, the crushing responsibility, the constant fear of making mistakes, the emotional toll of caring for strangers who become, even briefly, deeply important to you. For moments like this, for the chance to witness joy that almost wasn't, for the privilege of being the hands that kept someone's heart beating long enough for their own heart to remember how, for the honor of giving families back the people they love. After the ceremony, after Catherine and Emily both hugged me and cried and thanked me again, after I'd congratulated the newlyweds and met Catherine's extended family and eaten cake and made awkward small talk with other guests who wanted to hear the story, I drove back to my apartment and sat in my car in the parking lot for a long time. My phone buzzed. A text from Dr. Webb. "How was the wedding?" I typed back. "Beautiful." She walked her daughter down the aisle. I keep thinking about how close we came to that not happening. His response came quickly. But it did happen, because you kept going when stopping would have been easier. That's what separates competent doctors from exceptional ones, the willingness to push past the moment when hope seems lost. I sat with that for a while, letting his words settle into the complicated mix of emotions I was feeling. What if I'd been wrong? I typed. What if we'd kept going and she'd survived with severe brain damage? What if she'd lived but couldn't walk, couldn't talk, couldn't be herself? Then you would have made the best decision you could with the information available. Dr. Webb replied. Medicine is full of what-ifs, Noah. You can't let them paralyze you. You made a clinical judgment call and it was the right one. Learn from it and move forward. I pulled out my journal that night, a practice I'd started in medical school to process difficult cases and emotional experiences. I wrote about the code, about the 19 minutes of a systole, about the moment I felt that first flutter beneath my hands, about the wedding, and Catherine's smile, and the profound gift of witnessing a joy I'd helped make possible. Today I learned that sometimes hope is a clinical decision, that pushing past the protocol, past the statistics, past the point where textbooks suggest stopping, sometimes that's exactly what saves someone. But I also learned how fine the line is between perseverance and futility, between justified determination and denial of reality. I happened to be right this time, but I could just as easily have been wrong. And that uncertainty, that inability to know for certain in the moment whether you're making the right call, that's something I'll have to live with for my entire career. Dr. Webb says medicine is full of what-ifs. He's right. What if I'd stopped at 15 minutes? What if I'd kept going to 30 minutes? What if Catherine had survived, but with catastrophic brain damage that left her alive but not truly living? I don't have answers to these questions. I'm not sure anyone does. But I know that tonight, I watched a mother walk her daughter down the aisle 6 weeks after her heart stopped. And that has to count for something. That has to be worth the risk, the uncertainty, the terrifying responsibility of deciding when to fight and when to let go. 1 month after the wedding, during teaching rounds with medical students, one of them asked the question that haunts every young doctor. How do you know when to stop a code? How do you know when you've done enough? We were discussing a case of cardiac arrest, walking through the algorithm, and the student, earnest and nervous, reminding me of myself not so long ago, asked the question that has no easy answer. Dr. Webb was quiet for a moment, considering his response. Then he looked at me. Noah, you want to field this one? I thought about Catherine Morrison, about the flat line on the monitor at 15 minutes, at 17 minutes, at 19 minutes, about the ultrasound showing a motionless heart. about preparing to call time of death and then feeling that impossible flutter beneath my hands. Honestly, I said, there's no simple algorithm for this. The ACLS guidelines give us time frames, 20 minutes for asystole in most cases, longer if there's a shockable rhythm or special circumstances like hypothermia or drowning. But those are guidelines, not absolute rules. So how do you decide? The student pressed. You consider the whole clinical picture. How long was the patient down before CPR started? Are they responding to interventions, even slightly? Are there reversible causes we can address? What was their baseline function? Are we trying to restore them to meaningful life or just to biological existence? And sometimes, I paused, thinking about how to articulate something I was still learning myself. Sometimes you push past what the guidelines suggest because something tells you there's still a chance. And sometimes you stop earlier than protocols allow because you recognize true futility. But how do you know which is which? Experience helps. Pattern recognition develops over time. But even with experience, there's uncertainty. Medicine doesn't offer guarantees. We make the best decisions we can with imperfect information, and sometimes we're right and sometimes we're wrong. Dr. Webb nodded his approval. And you learn to live with that uncertainty. The physicians who can't tolerate it usually don't last long in acute care medicine. You have to make peace with the fact that you'll never be certain you made the perfect call. You can only be certain you made a thoughtful, evidence-based, patient-centered call. What if you make the wrong decision? The student asked quietly, voicing the fear underneath all the questions. I thought about how to answer honestly without being discouraging. Then you learn from it. You analyze what happened, what you could have done differently, what factors you might have missed. You carry that knowledge forward to the next case, but you don't let it paralyze you. Because if you become too afraid of making the wrong call, you'll hesitate in moments when decisiveness is required. And hesitation can be just as harmful as the wrong decision. 6 months after Catherine's cardiac arrest, I ran my 15th code. By then, I'd seen multiple outcomes across the spectrum. Some patients survived neurologically intact, walking out of the hospital days later. Some survived with deficits, cognitive impairment, physical weakness, requiring long-term rehabilitation. Some died in the ICU days after initial resuscitation, their bodies too damaged to recover. And some died during the code itself, despite our best efforts. I'd learned to recognize futility more quickly, to identify the cases where continuing would be cruel rather than caring. I'd learned when to push past the guidelines and when to follow them strictly. I'd learned to trust my clinical instincts while remaining humble about their limitations. This particular code was an 80-year-old man with end-stage heart failure who'd been chronically ill for years. When his heart stopped, I ran the resuscitation for 14 minutes before recognizing that his body, already ravaged by years of progressive disease, wasn't going to respond. Time of death, 4:23 a.m., I said quietly, and the team stepped back from the bed. It was sad, but it wasn't tragic. The patient had lived a long life, had been sick for a long time, and his body had simply reached its limits. We'd tried, but trying isn't always enough. After completing the death pronouncement, after talking to the family and expressing condolences, after finishing the documentation, I went to the call room and sat in the darkness for a while. 2 codes. 2 wildly different outcomes. Catherine, who'd survived against impossible odds. This gentleman, who hadn't. And I realized something important. I could live with both outcomes. Not easily. Death never comes easily when you've fought to prevent it. But I could accept both as legitimate results of thoughtful medical care. Because in both cases, I'd done my best. I'd brought skill and judgment to the situations. I'd made decisions carefully, consulted when appropriate, followed evidence while remaining flexible to individual circumstances. I couldn't control whether patients lived or died, but I could control the quality of care I provided, the thoughtfulness I brought to decisions, the respect I showed for their humanity. That was enough. It had to be enough. 1 year after Catherine's cardiac arrest, I received a card in the mail. The front showed a photograph of Catherine and Emily at the wedding, both in formal dresses standing together in the garden, sunlight streaming through the trees behind them, both smiling with pure joy. Inside, a handwritten note. Dr. Reyes, 1 year ago today, my heart stopped beating. You kept it beating with your hands for 19 minutes until it remembered how to beat on its own. I'm writing to tell you what this year has held. I watched Emily settle into married life. I celebrated holidays with family. I traveled to places I'd always wanted to see, the Grand Canyon, Niagara Falls, Yellowstone. I took up watercolor painting. I volunteered at a hospital support group for cardiac arrest survivors. Every morning when I wake up, I'm grateful. Grateful for life, for family, for second chances, for doctors who don't give up even when monitors show flat lines. My cardiologist says my heart function has actually improved slightly. It's still damaged, but my body has adapted remarkably well. He calls me his miracle patient, but we both know the real miracle was having a doctor willing to keep trying when trying seemed hopeless. Thank you for those 19 minutes. Thank you for believing I was worth saving. Thank you for showing Emily what courage and perseverance look like. With eternal gratitude and love, Catherine Morrison P.S. Emily is pregnant. You're going to be indirectly responsible for a grandmother meeting her grandchild. I hope that brings you as much joy as it brings me. I kept that card in my white coat pocket for the rest of residency, through fellowship, into my first attending position. On the difficult days, the days when patients died despite my best efforts, when I made mistakes that haunted me, when I questioned whether I was good enough for this work, I'd pull out that card and remember. Remember Catherine walking down the aisle with Emily? Remember that flat line transforming into a heartbeat at 19 minutes? Remember that sometimes, when you refuse to give up, when you keep pushing past the point where giving up would be easier and more defensible, sometimes you get to witness miracles. Not every time. Not even most times, but sometimes. And sometimes is enough to keep fighting, keep trying, keep bringing your best self to every code, every crisis, every moment when someone's life depends on your willingness to not stop.